Thank you very much, Doctor, for your testimony and your recommendations as well. A question for everyone, and then I'll ask some to each of you, and then yield to my colleague, Ms. Bass. As I asked of USAID earlier, Ms. McKenna, there is a 12.2% cut in the line item for nutrition in the official presentation from the administration, from $115 million to $101 million. There's also been a cut of 19% in tuberculosis, $236 million to $191, and there's a discouraging trend line in some of these recommendations for the budget. Even vulnerable children is cut by 34%, from 22 million to 14.5. And I'm wondering, again, thankfully budgets are dynamic processes, and this isn't the bottom line. Hopefully it will ratchet up from this. But what would that kind of cut do to the work, especially sometimes, other countries and partners take their cue from us. If we put a de-emphasis on something, will they, in corresponding way, do the same? Especially when, as you spoke earlier about the ratios, 18 to 1, and some of those other very, very unbelievable ratios in terms of investments made and consequences gleaned. Also, if you could, constructively speaking, criticism is good. I'm sure Ms. Bass, we get it all the time, given the nature of our jobs. And frankly, sometimes when it is well-meaning and properly focused, it really does cause recalibrations and changes in behavior in Congress, as it should. Sometimes it's just negative. Anything positive and negatively you could suggest with regards to USAID, here's your chance if you could. I'm sure you convey it privately, but I do think, they're grown-ups. It's good for them to hear what's working, what's not, and any suggestions that you might have. You, Dr. Perry, had a number of them, and one of them was to draft a comprehensive health workforce strategy. I thought we tried to do that in PEPFAR. There was a very significant, capacity building component to that legislation, particularly the first bill that was signed. But it would appear we haven't done it, well enough. So maybe you want to elaborate on that. And you also said the U.S. Congress should elevate U.S. government support for community health workers by insisting on funding child survival carry out by community health workers. Don't we do that? Is that something we need to revisit? And if you could elaborate on that either in written form or even now on exactly how we might do that. Ms. Boss, you, again, from a faith-based perspective, do you find that World Vision is discriminated against at all, or are you fully accepted as partners in this very worthwhile endeavor? Ms. Wetzel, again, if you could speak to that as well, and do you utilize existing religious networks? Do you find it's good, the go-to group that's already in country, build on their capacity and their roots, if you will, particularly from the sustainability point of view. Once the money dries up or goes elsewhere, it's always nice to know the work continues. Dr. Perry, again, you obviously, are well published, and I have to get that article that was mentioned earlier about that you wrote, or the op-ed. But the Lancet, I'll never forget this, back in 2008, and I read it, talked about and focused on undernutrition, and that if you didn't get it right in those first 2,000 days or so, what happens to that child is largely irreversible. You might want to talk about that and whether or not, there was a great deal of buzz and positive react to those early articles. Has that literature continued? Are we still writing about it, not we, but people who are experts in the field, to drive this train and do even more, and to elaborate on it, if you would. Dr. Aguirre, if you could speak about Guatemala and maybe elaborate a bit on that, because you have done a lot of work there. And it would be nice to get your insights into how that has worked, since USAID did provide significant funding there. Dr. Mendefro, the toxic stress, you did elaborate a bit on it. And I'm wondering, when you talked about, you stated that one study, researchers found a direct correlation between risk of fetal death and the amount of exposure to toxic stress that pregnant women were experienced when they were children. If you could maybe cite that study and maybe elaborate on that, because, and that's just some opening questions, and I'll yield to my colleague. Okay. Yes, Ms. Boss.
Sure. Thank you, Mr. Chairman. Regarding the FY15 budget, certainly as implementing partners of USAID, we work with them to try to do more with less where we can and be as efficient and effective as possible. Of course, we do always support robust funding of foreign assistance programs for the nutrition line items specifically because those interventions are so cross-cutting and so cost-effective. We would certainly support strong funding in that area. The community request for nutrition for FY15, I believe, is $200 million. So there is a significant gap there, which we appreciate Congress in the past having given strong support to the maternal and child health and global health programs at USAID. As far as recommendations for USAID or kind of our faith-based experience with USAID as a partner, we certainly feel like they value their partnership with us as we do our partnership with them. I would say that some of the movement at USAID has been more toward localization of aid. Often that means a definition of a local partner being a entity based in the country where USAID is putting in a program. Often that excludes international NGOs. Even though we have local staff, we have local partners with churches, other NGOs, and other organizations, it does exclude us from some of those programming if localization is a key component of that. So that is something that...
On that point, do you find or do you have concerns that, especially since you are so well audited and oversighted, both internally as well as externally, that those protections might not exist for an indigenous NGO that might have people who are friends of the health minister or others that where corruption might become a problem?
That's certainly something that could happen. I mean, certainly we have sound oversight both within our organization and externally to make sure that we're financially responsible. But really, at the end of the day, if the goal is to build up local capacity, faith-based organizations are so well suited to do that because we already work from a bottom-up perspective with the local communities. I mean, that's how you build the capacity, is with those local communities, and then you create the sustainability, the behavior change that lasts generation after generation.
Thank you very much for your questions, Congressman Smith. I would like to start out with your question about what I think USAID could do better to strengthen its support for child survival programming. As I mentioned in my testimony, I've been connected with the Child Survival and Health Grants Program for over 25 years now, and it was an outgrowth of your original legislation back in the 80s that Congress earmarked for Child Survival Program. It was an effort to provide funding directly to U.S.-based PVOs to work in partnership with local PVOs in developing countries to address child survival funding. It was a centrally funded program that has always been very small. The amount of money that has been given out by this program has never exceeded $20 million, and it has been going downhill for the last 25 years. And I find that to be an extraordinary observation given the fact that universally within USAID and outside of AID, this is seen as one of AID's very best programs for many reasons, which I won't elaborate on right now, but it does involve World Vision, Food for the Hungry, many other faith-based NGOs, PVOs, and non-faith-based organizations. But it provides an opportunity for the government to support the NGO efforts that originate in the United States to strengthen what they can do. But in my experience for more than 3 decades now, the creativity and innovation and deep passion and commitment that exist within the NGO community in the United States for child survival is extraordinary. And I think what USAID has done in developing this program has been excellent. They've developed a tremendous rapport, as you just mentioned, with the PVO community, but at this particular moment in time, it's the understanding of the NGO, PVO community that this whole program may be shelved. It hasn't been funded for 2 years now. And I find this extraordinary, given the success, the demonstrated success of this program and what it's meant in terms of developing the kinds of approaches and programs that we feel are so important to move this agenda forward in nutrition and other aspects of child survival. So I'd like to make a passionate plea that the committee gives special attention to ensuring in child survival funding that there is a serious effort made to engage the U.S. NGO, PVO community going forward and to greatly accelerate the amount of funding that has been made available to this program. I've asked over the years many times why this program has continually been cut back, and one of the answers that's been consistently given is exactly what Ms. Boss said a second ago, and that is that funding has been decentralized to the country level, so there's no money available at the central level to fund these kinds of programs. And this kind of funding is vital to engage the U.S. NGO community because frequently the U.S.-based NGO community within the country level doesn't have quite the same opportunity of operations that it does have by functioning as it has through the U.S. Child Survival and Health Grants Program for the last 25 years. So I hope I've made my point.
On that point, if you could, again, how much is actually been spent, not any for the last 2 years, from that spigot?
There have been no grants awarded by the United States Child Survival and Health Grants Program for the last 2 years, and there are none scheduled at the present time. Previously, the amount of funding was on the order of $20 million, and the project that I discussed that I evaluated with Food for the Hungry was funded through this mechanism, and I think it's a terribly important one for many reasons.
And what would be an ideal amount, in your view?
200 million, minimum.
Okay.
So,
you know, your thoughts comport with Niels Dallaire, who used to be very active over at USAID during.
Yes.
I know he has been concerned. Well, none of us want to see any lessening of the commitment to the HIV/AIDS, malaria, and tuberculosis efforts. We also don't want to see a crowding out of other worthwhile programs, robbing those in order to get to a critical mass. And PEPFAR certainly has been successful beyond our dreams in many, many ways, mother-to-child transmission and everything else, as well as ARVs.
But it takes money to be successful.
But that shouldn't mean that these other very important. So if you could give further thought, all of you, on I mean, we will fight to try to get this. That's why we're having the hearing. It is about that first 1,000 days. And it seems to me that when you talk about Millennium Development Goals, which again will be the post-2015 goals will come up with a whole new set, but the laggard has been child mortality. As one of you said, and I have to remember which, you know, we should celebrate, I think, as you put it, was it you, I think, you know, the success has been made, but there's so much that we have not done as a world or as a country to try to mitigate the problem of child mortality that is right within our grasp.
Right.
So, you know, 200 million, whatever you think, I mean, we need a sustainable and a very accurate number to fight for it. And I know that members of Congress are very, you know, open to, and I know that because I talk to them about these issues all the time, to making sure we get it right. So that's why this hearing is being held, frankly. So
I'll be happy to address your other questions, but I think
Please
I've taken more time than
No,
I should, so maybe we could.
we'll get to everyone, if you don't mind.
Yeah, so, I mean, you had some other questions about
The Lancet study.
about our support for community health worker programs and our comprehensive health workforce strategy, and also the issue about what's the current status of knowledge about undernutrition. So let me just very briefly make a comment about those. There have been programs supported by USAID that involve community health workers, but we're at a new stage where we need to professionalize our community health worker workforce, which has not happened before. There are going to be more and more interventions that can be provided at the community level, but we need to learn how to integrate these together in an effective system that can be sustained over time and that can be effective, and that is what we have not been funding so far. So we're going to continue to need to build a system, and it's an integral part of a health system strengthening approach. And in my experience, health system strengthening is being recognized more and more as an important area for our involvement. But too often, health system strengthening has been limited to services that take place at facilities without giving full recognition to the critical role of communities and community-based delivery in terms of improving population health. And it's not recognized by ministries of health still. It's an area that needs a lot of work and support. My only comment about undernutrition is that there was a recent series in The Lancet that was published only a few months ago that updated the 2008 Lancet series that you mentioned that was led by Dr. Robert Black at Johns Hopkins. And their conclusion is that 54% of child mortality can be attributed to undernutrition. And in the 2008 version, I think they were seeing something like 38% or something like that. So, I mean, the science has continued to stress the importance of undernutrition as a fundamental part of improving mortality, reducing mortality, improving child survival in the first 1,000 days of life. The problem is that so much of our aid is focused on curative health systems and not driven down to the community with behavior change communication, hand washing, exclusive breastfeeding, very simple low-cost things. These have not been given the kind of attention that other sort of medically oriented interventions have gotten in the past, and it takes a change of mindset that we're still struggling to bring about in the donor community.
Without objection, the most recent Lancet studies that you mentioned by R.E. Black will be made a part of the record, and I thank you for reminding us that.
Yeah.
Very important. Dr. Wetzel-Chen.
Thank you. First, responding to your question about recommendations for the U.S. government. For one thing, I would say we've really appreciated USAID's focus on improving their monitoring and evaluation. So for many years, we were doing programs. There wasn't a heavy focus or guidance put on how to do baseline surveys, how to do follow-up, so that it was unclear what was really working. So that support and initiative by the government is very helpful. Secondly, we have appreciated multi-sector and multi-year funding from the U.S. government. One of the programs that Food for the Hungry has been able to rely on over many years has been your food security programs. So those cover nutrition, but they also include agriculture, livelihoods, and they provide an excellent base for us to really make changes in the community. They are typically 5-year programs, and that is what is so key. When we are funded for 1 year or 3 years, it's very difficult to see behavior change happening and make an impact. So that long-term funding makes a world of difference. Another thing that we always face as a challenge is contextualizing our programs. So there's usually a push when once we're funded to start implementing right away and see impact. But what we need to do is step back and say, what are the specific barriers that are preventing what has worked maybe in other places from working here? And so allowing a lead time where we can do investigative work would be very helpful. DFID recently started doing programming slightly differently, where they would select an organization or a consortium, and then they would say, okay, you have 6 months to do studies and develop your full proposal. That seemed like a great way to really allow us to make impact through the programs. Thirdly, I'd like to recommend to comment on the restraints that we've seen in terms of local NGOs. So as Ms. Boz shared, as an international NGO, we have seen that our funding, it's becoming more competitive. It's difficult. We don't feel that we're being discriminated against in any way as a faith-based organization. We can come to the table, compete for funding, just like any other international NGO. But as Ms. Boz was sharing, 97% of our staff worldwide are nationals of the country where they work. But we're unable to access more and more of the funding that is made available because we're not considered a local NGO. And there's a lot of strength and capacity that comes from having global service centers that support our field operations. We find that with the funding that we are able to win, we're using more and more resources to build the programmatic capacity of local organizations versus the technical impact of the program. Fourthly, I'd like to say we could we've appreciated the U.S. government's focus on capacity building grants and initiatives. For example, the CORE group. This is a group of maternal and child health technical implementers, NGOs. They come together twice a year. They have working groups, some focused on nutrition. That has been a great place for the sharing of technical innovations, of best practices. The TOPS initiative by the U.S. government. In years past, there was the Institutional Capacity Building Grant. Those are great ways to get out what works to NGOs that are implementing that. Your question was about community health workers. Well, as I combine that with recommendations for the government, I would say there's been a focus lately on innovation. And while I applaud that focus, it often means that what we have seen to work is harder and harder to get funding for. A lot of it isn't rocket science. Breastfeeding, ORS, it works and it's simple, but it's not happening at the level that we want to see it happening. So balancing that focus on innovation with funding what really works is important. And that relates to the community health worker question. That is funded, we have seen that going on, but it's not scaled up. In so many countries where Food for the Hungry enters, there may be a community health worker initiative, but you may have one person trying to reach thousands of households. And what we've seen work in our care group approach is that we take one community volunteer, that person reaches somewhere between 10 and 12 neighbors. So it's peer-to-peer education, and social and behavior change research has shown that that's what really creates the changes at the household level. So we need not just a community health worker system, but one that research has proven is effective in creating behavior change. That's my comments. Thank you.
Dr. Aguirre?
Yes. Well, I will focus specifically in Guatemala since this is what you have requested from me. I want to say that when you look at the funding allocation in the case of USAID in Guatemala, as more than 30% goes to democracy and governance, something that is not surprising given the conditions of Guatemala at this point in time. We know it's a very conflicting and high crime country at this point in time. And so having worked specifically on red zones or areas of high crime in this country, we see the consequences for the malnutrition and et cetera that we are dealing with here today because of crime, because of the lack of security, et cetera. Broken families, widows. I have research areas where the average family structure is a widow because the husband had been killed in entire areas in departments in the country. So that's to give a framework that is not a misallocation of funds when you think in terms of long-term growth in a country and the consequences of the high costs that lack of democracy and governance have and security have in a country. That being said, though, I would say that I will find it difficult to justify the high level of funding that in Guatemala is placed today on family planning, and is disproportionate given the needs of the country. We are talking about almost as much as allocation for democracy and governance when people are dying of malnutrition or lack of access to clean water or basic education. So if I have one comment I have to make is about the allocation of funding from an economic point of view, I will be called inefficient, as it does not meet the requirements of long-term growth for that country. Together with that, though, I was thinking other areas where I've seen very interesting work done, and USAID has been part of it, is the public-private initiatives that have been taking place in Guatemala. I've been working there for several years, and what I've seen specifically since 2007 has been a significant growth of public-private initiatives where you see a USAID have played a good role in some aspects, for example, in the area of education, of agriculture, of HIV. So there are areas where are very good. However, I wish I would see much more engagement on the part of USAID for the purpose of areas of malnutrition, where you have very good community-based private initiative programs, long-term investments in communities, in very needed communities, for example, as there's in the north of Guatemala, and Alta Verapazes, where we have very high level of malnutrition and hunger. There are very good initiatives taking place in that. There are long-term investments, as my colleagues have mentioned before. Those are the ones who really find long-term solutions. They take 3-4 years investment in the different communities. USAID have been not really a partner in those efforts. And it will serve them well to do so. Also, the lead time. I think this is also a very important issue. When you look at some of the investments of USAID, I will surrender that they lack on institutional acknowledgement or reality of what are the values that these countries wants to hold, what are the cultural backgrounds that take place in that country, and that sometimes the programs promoted by USAID not only misplace the authority, I should say, for example, by ignoring parents when we are talking about minors, but also by the type of programs that or educational programs that they propose, especially in the area of sexual education and family planning. And I want to emphasize this because I have found it in my own data. And that is that access to family planning contraceptives, safe sex type of education among some of these, in this red zone areas, as they call, high crime areas, not necessarily has been helpful for early pregnancies, for example. In fact, has increased early pregnancies, and it has misplaced the emphasis. Unfortunately, in Guatemala, you have a lot of child abuse. The data is across the country. I can say it now because I've done research everywhere. And it's an area that systematically we ignore. It's interesting enough, right? Where we have, we offer all type of methodologies for contraception, we ignore the fact that we have child abuse. And the consequence of that, for lasting consequences for that in children. So there are some areas where I think USAID has done a fantastic job. And there are some areas where I'm greatly concerned because I really think it's a misuse of funds, especially when we are talking about cutting budgets. It might be worth it to take a serious revision, especially looking at the goals that they have proposed for the rest of the, from here to 2016, as per their report. Thank you.
So at this point, I feel like I'm just echoing my colleagues, which I will do happily. But first of all, I could not agree with you more in terms of the child abuse statistics. They're really disheartening. And one thing that continues to amaze me in my work is wherever I go, across cultures, across race, across economic divides, the numbers are startling, and it's about 1 in 3. And if we're looking at specifically at sexual abuse, actually it's 1 in 3 before the age of 18. And when you have a population risk factor that is that big, we can't afford to ignore it. So I guess my first comment would be is really getting USAID to do more in the sphere of mental health. And I think as a whole in global public health, we have a long way to go. And I say this to you as an internist, as a primary care physician, not even as a mental health specialist, because I've seen it. I truly believe that physical health begins with mental health. And I think a correlate point to that is that you know, to the point you raised about behavior change programs, behavior change is about psychological health and well-being. I mean, we know that even from the scientific literature in this country, 40% of our premature deaths are due to behaviors. And it's a very tough issue, which is why it requires investment, and I think why Congress can kind of place some restrictions about at least a certain percentage of the global public health assistance program really being directed at behavior change and, more importantly, addressing these large issues of abuse. The second point, to the community health workers point, I couldn't agree more about the need to professionalize, and I just wanted to name 2 projects in particular. In Ethiopia, there's been actually a lot of headway with the Ethiopian Health Extension Workers Program, and a lot of their materials can serve as an exemplary model of how you professionalize, in addition to the brave and pioneering work of Partners in Health in Haiti and Rwanda, are truly like exemplary programs of how you can do this community health worker approach and take it to scale and get some real lasting effects. And then to your point, Chairman Smith, the study that I cited, and I think I might not have actually included the reference in my original written comments, it comes out of a literature on child abuse actually in this country. It's a 2004 Journal of Pediatrics study by Susan Hillis and Al. There's a lot of authors, but it's actually the original authors who came up with the Adverse Childhood Experiences study. And it's a study that looked at, it's a retrospective cohort study, so they looked back on these experiences of 9,159 women over the age of 18 who attended a primary care clinic in San Diego. And what they looked at was adverse childhood experiences as scored from 1 to 8. And these are really a list of things like physical abuse, emotional abuse, sexual abuse, experiences of violence, household dysfunctions, all kinds of measures. And when they stratified this, the highest group, which had an experience of 5 to 8 of these adverse experiences, had an increased risk of 80% in fetal death. So fetal death was actually one of the outcomes they looked at, and I can give you the specifics for that reference.
Thank you very much, and for all of you, Ms. Bass.
Thank you very much.